I'm Dr. Matthew O. Leavitt. I'm a practicing pathologist with a focus on innovation in digital pathology. Formerly, I was the pathology department chair in a regional medical center in Utah, where I gained a lot of practical experience in the fundamental issues we'll be discussing today. About 6 years ago, I left that hospital-based practice to found a lab technology company that's developing technologies to address many of the issues we're talking about today. So to avoid conflict of interest, I will not mention any of the specific products or technologies we've developed, and I'll focus my lecture on helping you to gain a deeper understanding of some of the critical but often neglected issues in genitourinary pathology which can affect the quality of care we offer to our patients. First of all, I'd like to thank the organizers of EuroEd and for providing me with this chance to talk about these important issues. Let's begin by reviewing the objectives of today's lecture. Today's lecture is the first of a three-part series. Each part will discuss different issues relevant to GU pathology and urology. In this first lecture, called Tissues with Issues, Problems Created by Current Prostate Biopsy Tissue Handling Procedures, we'll focus on the way that tissues are handled and how that impacts prostate cancer care. Tissues with Issues Part 2 will focus on problems in current prostate cancer pathology practice, namely the current grading systems and problems with inter-observer variability, non-standardized molecular testing, and the role that artificial intelligence can play in prostate pathology. In our third segment, called Bridging the Diagnostic Divide, we'll discuss how the integration of digital diagnostic technologies will improve how we care for patients with prostate cancer. We'll talk about the problem with the siloed data between clinic, laboratory, radiology, and genetics. We'll talk about how digital pathology is a keystone in bridging the diagnostic divide, and we'll talk about the promise of integrated diagnostic data. Tissues with Issues, Part 1. Today we're going to talk about how archaic ways of handling tissue limit our ability to provide precision diagnostics to our patients. We'll start off by just discussing the pathologist's role as a provider of diagnostic intelligence. Then we'll review current tissue handling methods, and then we'll end by emphasizing how suboptimal tissue handling can reduce the quality of the diagnostic intelligence the pathologist is able to provide, and how this can actually lead to harm for our patients. Let's start by discussing, in general terms, the role of the pathologist. The pathologist is there to provide information about a patient's disease and to inform patients and their physicians as they make these critical and potentially life-changing decisions. If you were to liken the practice of medicine to a war on disease, then the pathology lab is analogous to military intelligence. Pathologists generally operate behind the scenes, usually in the basement of hospitals, gathering data about the patient and their conditions and analyzing that data to provide patients and their caregivers with the best intelligence and hopefully enable them to make the best decisions. Anatomic pathologists are specialized in analyzing tissues. These tissue and sometimes fluid samples are rich sources of hidden information. There's a lot of data in those samples. And the data in those samples can provide critical clues as to how to best treat the disease. The microscopic patterns that were described decades, and in some cases centuries ago, still form the foundation of our understanding of disease. So today's pathologists stand at the threshold between the old world of manual microscopic diagnostic classification and a new world of multimodality computer-assisted diagnostics. The problem is that our current methods for handling the fragile, delicate tissue samples that come out of the patient, those were designed for manual microscopic classification and not for molecular or computer-assisted diagnostics. Now let's move on to current tissue handling protocols and the problems those methods create. So let's start in the clinic. A patient comes in for a biopsy, and that patient there needs to be information gathered on that patient about why the biopsy is being performed. A pathologist can't make a diagnosis in a vacuum. Generally, that's done on requisition sheets still done with paper. And that piece of paper and the hand-labeled formaldehyde bottle are the links between that patient in the clinic and the laboratory. So the biopsy's taken, it's often placed into that formaldehyde jar. Oftentimes it will break up as it comes off the needle, and then the patient's name is either handwritten on that, and the site of origin is placed on that bottle. So that tissue gets transported to the laboratory, and sometimes that happens if you're in a hospital. It may just be a few minutes that it's in that formaldehyde bottle before it gets to the lab, or if it needs to go into a shipping container, it may take a few days. I often hear people say that pathology is like a black box. They put tissue in and they get back a result. It's more like the old magic 8 balls. You ask it a question and shake it up, and then an answer magically appears. Because in this case, the urologist puts the tissue into a container and asks the question, is it malignant or not? And then it literally does get shaken up, but this time not by the urologist, hopefully, but rather by those who are transporting that tissue and that container to the laboratory. So here we are in the lab, after all the bottles and cassettes have been lined up according to their accession numbers. And the technician swishes the bottle just to check where the cores are, and then carefully fishes out each tissue core fragment and places them carefully into the labeled cassette. And you can see that the tissue is fragmented due to that shaking. And the technician has no idea whether this was a single needle core pass or multiple. He or she just fishes out what's there, measures it, and then documents the length of each core fragment. It's then sandwiched between 2 sponges and then placed in the tissue processor. And that sponge creates other problems, which we'll discuss later. He then moves on to the second core biopsy, looks in the container for tissue, but then finds it trapped in the threads of the lid. This happens in large laboratories every single day. The purpose of tissue processing is to infuse the cells with paraffin. The reason that the cells need to be infused with paraffin is so that we can cut very thin, 3 to 4 micron thick sections. The histologic sections need to be extremely thin and regular in order to allow light from the microscope to penetrate the cells. So infusing the cells and tissues with paraffin enable the histotechnologist to section that tissue at 3 to 4 microns thickness. And in order to be able to infuse cells with paraffin, which is a more lipophilic substance, all of the water in those cells needs to be removed. So this is during the tissue processing, water is removed from the cells. They're dehydrated through a series of steps with various concentrations of alcohols. The concentration of alcohol increases with every step, and that enables the water to be removed gradually from the cells. This is usually done in automated tissue processing machines. But interestingly, the actual protocols haven't changed in over 100 years. We still use the same types of alcohol, the same buffers. In most labs, tissue is processed sandwiched between sponges. During processing, the tissue cores shrink, and they become brittle and frequently form unusual non-linear shapes. Since the paraffin sticks to the sponge, paraffinized cores often fragment, and as they're removed from the sponge, they break up, which makes it difficult to embed them all on the same plane of section in the tissue block. The challenge at that point is to try to embed those nonlinear fragments into a single plane so that they can be sectioned on the microtome and capture as much tissue as possible for the pathologist to examine. Embedding is a totally underappreciated step in this process. Embedding is when those tissue cores, those small tissue fragments, are placed into that paraffin tissue block. And the way those tissue fragments are embedded determines the geometric plane which the microtome blade needs to be set to in order to achieve a full cross-section of those cylindrical tissue cores. And achieving a full cross-section of each core is critical. Without having a full cross-section, there's a high percentage of the tissue that just doesn't get examined. And that is one of the leading causes of false negative tissue biopsies. So whether a tissue biopsy is fully examined by the pathologist is often determined by the quality of the embedding. It's hard enough to find the exact plane of section for one cylindrical tissue core, but imagine the difficulty in trying to section a nonlinear tissue core or even multiple nonlinear tissue cores on the same plane. It's nearly impossible, which is why most high-quality labs only embed one tissue core per block and slide. Doing this adds considerable time and expense to the process, but until now, it's been the only way to be able to ensure full cross-sections. Again, my company has been working on ways to improve the amount of tissue on the slide and to also reduce the costs. And again, I'll refer you to our website to learn about that rather than talking about it in this venue. Now that we've reviewed standard tissue handling protocols, you're prepared to understand how our current tissue handling methods can reduce the quality and reliability of the diagnostic data that's so important to making good clinical decisions. We'll briefly discuss now 5 serious problems that are created by our suboptimal tissue handling and data handling environment that can truly cause harm to patients. The first is discontinuous workflows. The second, core fragmentation. Third, a lack of tissue orientation. Fourth, variable formalin fixation and processing protocols. And lastly, rather generic one but critical, and that is our current environment of diagnostic data silos. So let's start on discontinuous workflows. What do I mean by that? Pathology labs are unusually disconnected from the other parts of the healthcare system. We're disconnected from the people who directly interact with the patient. The path lab's not only physically located far from the clinic, but lab personnel usually work on completely different, disconnected lab information systems. And while most other clinical subspecialties are beginning to integrate their electronic medical records, and they have connectivity to lab results, in most places, communication between clinic and pathology lab is still being carried out mostly on paper requisition sheets and fax machines. This means that handwritten patient and specimen data must be manually transcribed by multiple people in multiple locations, which increases the likelihood of specimen switches and miscommunication. The most devastating errors that I've seen that are made in the pathology lab are usually not interpretive errors, but rather a mislabeled specimen or container or a switched tissue block or slide mislabeling issues. Every day in every country in the world, patients are harmed by the errors in specimen identification. So I make this one of the serious issues that we need to face if we're going to improve pathology. And in an era of cloud connectivity, one would think that we would have solved this by now. The most effective way to eliminate human specimen labeling errors is to eliminate human labeling altogether. So we're going to discuss more of this in part 2 when we discuss the practice of digital pathology. Let's go on now to core fragmentation. So after seeing the problems with formalin bottle fixation, specimen transport, and core handling during the gross examination and embedding, I think you can see it's easy why core fragmentation happens and why it's one of the most common problems we encounter in the lab. But I think it's more important for you to understand why this actually matters. So fragmentation happens in prostate biopsies in about 30% of cases, and it really can affect the diagnosis and the management of the patient. And the key here is that fragmentation is generally a function of specimen handling. The more you handle the specimen at every point along that patient's journey, the more likely you are to have fragmentation. And it's particularly important during specimen procurement in the clinic and during transport. And again, this is a place where I focused a lot of my career. And if you go to the website for my company, you can find out more if you're interested in this and how we've tried to solve this problem of specimen fragmentation. Here's why it matters. There are two types of reporting errors that are frequently created by fragmented specimen. One is errors in the quantification of the tumor. What is the percentage involvement of the tumor? And you can see from this diagram on the left side how the same cores can be interpreted very differently if they are fragmented, and the percentage involvement changes completely. Either it goes up or goes down depending on where the cancer is relative to the fragment. And then on the right side there you can see the other problem is core enumeration errors. If the clinic doesn't communicate well, which is often the case, how many passes they took, the pathologist has no idea by the time it gets to his or her microscope how many cores there actually were submitted in the clinic, because this fragmentation could happen any place along the way. So this kind of reporting error can misinform clinicians and lead to mismanagement of patients. All right, let's move on to the third potential area that tissue handling can cause harm to patients, and that's lack of tissue orientation. Current tissue handling protocols do not provide orientation on the tissue cores. It takes time to ink those specimens and to identify which tip is the distal needle tip. And in the past, it really didn't matter. But now, as focal prostate cancer therapy options are growing, there's an increased need for precision diagnostics, the ability to locate tumor foci and to be able to correlate those tumor foci with digital imaging modalities. It's increasingly important to understand not only the grade and general location of the tumor, which is what we provide today. With focal therapy becoming more and more common, it will only be effective if pathology can begin to provide precise localization of small tumor foci, as well as the spatial relationships between those tumor foci and the relationship of those tumor foci with surrounding anatomic structures. So to achieve this kind of precision localization, pathology has to be correlated with high-resolution radiologic images. And to make that correlation between pathology and radiology, pathology simply has to be digital. So in part 2 of this series, we will explain how standardized handling of wet tissue is the critical missing link that not only enables efficient digital transformation in pathology, but it also enables the integration of digital pathology with radiologic imaging. Let's go on to the fourth issue, and that is the variability in formalin fixation and tissue processing. It sounds like a boring subject, but the reality is it's wreaking havoc in the molecular testing world. As I mentioned earlier, formalin has been pathology's favorite tissue preservative for over a century, and we've been able to look past the fact that it smells bad and it burns our eyes and our throat. We've turned a blind eye to the fact that it's a terrible carcinogen. Now, though, we have another and perhaps more compelling reason to think again about our favorite carcinogen in the lab. It's now messing up molecular testing. Formalin preserves tissue by forming cross-links between soluble and structural proteins in the cell, which inhibits the breakdown and degradation of cellular structures, proteins, and nucleic acids. While it preserves nucleic acids from degradation, excessive formalin cross-linking around nucleic acids blocks primers and test probes, which can lead to unreliable results. So given our inability to control the amount of time specimens sit in formalin as they're transported between the clinic and the lab, we really struggle to control or standardize this cross-linking. And this is one of the biggest challenges facing molecular profiling labs. There are other ways to fix and preserve tissue that avoid the pitfalls of formalin, so why do we stick with it? All fixatives and all preservatives create different artifacts, including formalin. In other words, tissues fixed in formalin look different than tissues fixed in buffered ethanol or any other preservative. And we've become accustomed to formalin and have standardized our labs and our treatment protocols around diagnoses made with formalin-fixed paraffin-embedded tissue, good old FFPE. So while we acknowledge the problem and we would all like to change it, change will likely be incremental and slow because much of our diagnostic foundation is intertwined with this imperfect fixative. Tissue processing is another variable that is vastly different as if you go from one lab to another, and different tissue handling protocols yield differences in molecular testing results. This is probably easier to change than the fixative, and as molecular and companion diagnostics continue to increase in their import, the practice of pathology as a whole needs to adapt, develop, and agree upon some standard tissue processing protocols. And we'll discuss this more in the third part of this series. Okay, we're going to end now on the diagnostic data silos, and we'll just say a little bit about this, and I think, again, most of this we'll cover in the third part. The diagnostic intelligence required to provide our patients with the best care possible is not currently very easy to assimilate. And this is because it exists in silos. The clinic has its EMR, the lab has its LIS, radiology has its RIS. Genetic testing companies have their own lab information system, and they usually interface with clinicians and patients with paper results or PDFs, and they're not integrated at all with the other diagnostic modalities. If you're lucky enough as a patient or a physician in a setting where people are collaborative, multimodal diagnostic intelligence sharing happens in tumor boards, where providers do their best to synthesize the data from all of these different sources. But in the future, we have the potential for something far greater. If we really want to get the most out of our diagnostic intelligence, we need to bring these silos together. We need to break down the barriers between the different subspecialties and integrate clinic, lab, radiology, and genetic data. If we do this, we will open up new worlds of understanding and new therapeutic pathways. So that's all for today. If you want to continue and learn more about this topic, I'd encourage you to listen to Part 2 and Part 3. Our next segment, Part 2, will focus on diagnostic interpretation of prostate biopsies in the digital age. And while this applies to all fields in pathology, we're going to focus on how digital pathology can be a keystone in bridging these different diagnostic modalities. Thank you.